All right, today we're diving into one of the most catastrophic emergencies in all of vascular surgery. It's rare, it's incredibly tough to diagnose, and when it hits, the clock starts ticking on what is almost always a fatal outcome. We are talking about a condition where the body's main fuel line springs a leak in the absolute worst possible place. So I want you to picture this, the aorta. It's the biggest artery in your whole body, like a massive high-pressure pipeline carrying blood from your heart to everywhere else. Now imagine that pipeline, under all that pressure, forming a forbidden connection directly into your digestive system. It's a scenario that just shouldn't be possible, but when it does happen, the result is an aortoenteric fistula. You know, the craziest part is that the first sign of this disaster is often deceptively small. It's something called a herald bleed, a little bit of GI bleeding that might even stop on its own. It's so easy to dismiss, but that's not the end of it. It's a prelude. It's like the first tiny tremor before a massive earthquake, a deceptive calm before an absolute storm.
So how does this thing actually present itself? Let's break down the classic but oh so elusive signs.
Way back in 1829, Sir Astley Cooper first laid out what we now call the classic triad of symptoms. Number 1, GI bleeding, which, as we just saw, can start with that sneaky herald bleed. Number 2, abdominal pain. And number 3, a pulsatile mass in the abdomen. And I mean that literally. A doctor can feel the patient's pulse just by pushing on their belly, because the aorta is so enlarged.
But here's the kicker. That classic triad, the 3 things you'd think every doctor is looking for, well, all 3 of those symptoms show up together in only 11% of cases. Just 11%. That's what makes this thing so incredibly hard to catch. It almost never reads the textbook.
Okay, so if the classic signs are basically a misdirect, what exactly is this deadly connection we're talking about?
So here's the bottom line. An aortoenteric fistula, or AEF, is a direct tunnel between the super high-pressure world of your circulatory system and the low-pressure, bacteria-filled world of your gut. And let me be clear, these two systems are never, ever supposed to meet. When they do, it opens the door for catastrophic bleeding into the gut and a massive flood of infection straight into the bloodstream. And it turns out, this can happen in a couple of different ways. First, there's primary AEF. This is when the body's own aorta fails. Usually an aneurysm gets so big it just erodes its way into the bowel. It's incredibly rare. What's more common, and in a way more tragic, is secondary AEF. This happens when a previous aortic repair, a graft that was put in to save a patient's life, fails years later and creates that same deadly connection.
So you gotta wonder, how on earth does this even happen? How does the body's biggest, toughest artery just break down and connect with the gut? Well, in a primary AEF, it's often this relentless mechanical process. See, first the aorta's wall gets weak and starts to bulge out, forming an aneurysm. This big, pulsing mass then starts beating against the wall of the intestine, which is sitting right next to it. And over time, that constant, throbbing pressure just erodes both walls, kind of like a river carving its way through rock, until, boom, a channel forms between them. For secondary AEF, the causes are usually tied back to that original, life-saving surgery. Maybe an infection got in at the surgical site, or maybe the synthetic graft itself, which is way stiffer than a natural artery, created a pressure point that slowly wore away the bowel. It could even be a subtle technical slip-up during the first operation that created a weak spot, just waiting to fail years down the road. So, we know what it is, we know how it happens. Now, the whole game shifts to the diagnosis, and it is an absolutely desperate search against a rapidly ticking clock.
And that clock is completely unforgiving. After that first little herald bleed, the risk of a second and likely fatal bleed is just enormous. The chance of it happening again is 30% within just 6 hours. It jumps to 50% within 24 hours. There is absolutely, positively no time to waste. So how do you even find this thing? Well, the main workhorse here is the CT scan. It's fast, it's non-invasive, and it's got the best detection rate at around 61%. An endoscopy, the camera down the throat, that only spots the fistula about a quarter of the time, but it's super important for ruling out more common causes of bleeding. The real takeaway here is that no single test is perfect, which is why that gut feeling, that high level of suspicion, is just so critical. Once the diagnosis is finally made, it's a mad dash to the operating room for what is, and I'm not exaggerating, one of the most difficult procedures in all of surgery. I mean, think about what the surgical team is up against. They have to solve 3 massive, life-or-death problems all at the same time. 1. Stop a catastrophic hemorrhage from the body's largest artery. 2. Patch up a hole in the contaminated intestine.
And 3, completely rebuild that main arterial pipeline. And to top it all off, they have to do all of this in a surgical field that is almost certainly infected.
One of the classic ways to tackle this is to basically create a detour for the blood. It's called an extra-anatomic bypass. The surgeons go in, they remove all the infected material from the abdomen, they close off the aorta, and then they reroute all the blood flow through new grafts that are tunneled under the skin, completely bypassing the contaminated area. Sometimes they run a new pipeline all the way from an artery near the armpit clear down to the legs. Now, the other major strategy is a direct replacement, or what surgeons call an in situ repair. So instead of building a detour, they go right into the heart of the problem. They take out the infected aortic graft and they replace it right then and there with a new, specially treated infection-resistant graft, sometimes using a cryopreserved human artery from a donor.
But even with these absolutely heroic surgical efforts, the fight for survival is, well, it's a true battle against incredible odds.
And this is where you see the stark reality of the whole situation. It's brutal. Without surgery, the mortality rate is 100%. 100%. Nobody survives. With surgery, the average mortality rate is still a staggering 30 to 40%. It's an unbelievably high-risk operation, but it is also the patient's only chance.
So after all of this, what's the most important thing to take away? It comes down to this single quote. Before any of the fancy scans, before the incredibly complex surgery, survival starts with a thought. It begins in the mind of a doctor in an ER somewhere who sees a patient with a GI bleed and a history of aortic surgery and thinks, wait a minute. That high level of suspicion, that intuition, that's often the first and most powerful weapon there is in this fight for life.